Gynecologic pathology. Causes of abnormal uterine bleeding. In the prepuberty, there can be endocrine diseases. In the adolescence, we can have cycle coagulation disorders. In the reproductive age, we can have pregnancy-related problems, polyps, hyperplasia, benign and malignant tumors, dysfunctional uterine bleeding. In perimenopausal age, we can have polyps, hyperplasia, and malignant tumors, dysfunctional uterine bleeding. Postmenopausal age, we can have endometrial atrophy, polyps, hyperplasia, and malignant tumors. Another way to approach the causes of abnormal uterine bleeding is to take into consideration the age of the patient. If bleeding is in puberty, it's very unlikely to have cancer behind that problem, whereas in postmenopausal age, this is the first thing to think about. Embryology concepts are useful to understand histogenesis of urogenital tract tumors. Some structures derive from germ cells, which early migrate to yolk sac at 4 weeks, then urogenital ridge is formed at 5-6 weeks, then proliferation of mesodermal epithelium occurs, and finally ovarian epithelium and ovarian stroma are formed. This is why some tumors derived from these structures are named germ cell tumors. Paramesonephric or Mullerian duct is a structure giving rise to fallopian tube. Another possibility is that paramesonephric ducts converge at urogenital sinus to build up a structure called Mullerian tubercle, which gives rise to uterus and upper portion of vagina. The lower part of the vagina instead is formed by the urogenital sinus. During embryological development of the female genital tract, there are also some male structures, which usually regress, called mesonephric or Wolffian ducts. Sometimes they may not completely regress and stay in areas like parametrial areas, that is, around the uterus, where they can give rise to cystic degeneration. The anatomical compartments are the vulva and vagina, the cervix, and the body of uterus and endometrium. Infections. These are the most frequent associations between pathogens and clinical picture, which may give you a hint about which is the pathogenic microorganisms. The major risk of infertility is due to Neisseria gonorrhoeae, chlamydia, Mycoplasma pneumoniae, and the Mycoplasma and Chlamydia trachomatis. Preterm delivery can be due to Uroplasma oralyticum and Mycoplasma hominis. Important morbidity is also due to herpes and papilloma. The infections typical in the lower tract are herpes simplex, which is the most frequent in the cervix, but may also be present in vagina and less frequently in the vulva. HSV2 is more common than HSV1. About 1/3 of less than 40-year-old women are seropositive. They are often recurrent. Molluscum contagiosum due to pox virus, MCV1 most prevalent but less dangerous. It is a pox virus. Molluscum contagiosum virus 1 is most prevalent but less dangerous. MCV2 is most sexually transmitted in adults. Fungi can be candida, which implies also an impairment of neutrophilic and Th17 function, so regulatory function. Protozoa such as Trichomonas vaginalis, strawberry cervix, bacteria like Gardnerella vaginalis, gram-negative Coccobacillus, and others like Uroplasma oralyticum, Chlamydia trachomatis. Then we have infections shared both by lower and upper female genital tract. One such situation is pelvic inflammatory disease. It's an infectious disease developing in vulva or vagina and spreading to upper structures of female genital tract. The cardinal signs are pelvic pain, adnexal tenderness, fever, vaginal discharge. These symptoms may get silent and then recur very frequently. The situation of tenderness and hard abdomen somehow resembles peritonitis. The most involved organisms are Neisseria gonorrhoeae, chlamydia, purpura infections, so polymicrobial. Peculiarities are within pelvic inflammatory disease, some aspects can suggest you the most likely bug. For example, a gonococcal infection is typically an acute suppurative infection. Curiously enough, the endometrium is quite spared. No one knows why. You should think about gonococcal PID whenever you have this sequence of pathogenic events: salpingophoritis, tubovarian abscess, and pilosalpinx. That is a salpinx filled with purulent material, hydrosalpinx in chronic. It becomes hydrosalpinx in chronic phases. This is relevant because these purulent structures are difficult to be reached by antibiotics since they're walled off. Non-gonococcal infections, on the other hand, have major tropism for serosal surfaces, ligaments, pelvis structure, and peritoneum. PID of any kind must be stopped as soon as possible to avoid complications. Disorders of the vulva can be neoplastic or non-neoplastic. The non-neoplastic is lichen, which is a lesion of autoimmune etiology, usually occurring in the oral cavity, divided in planus and sclerosus, in which there is deposition of fibrotic material. The neoplastic can be squamous, so uh, vulvar intraepithelial neoplasia ranging from grade 1 to grade 3 is the precancerous condition. Basaloid and vorticarcinoma, 30% are HPV related or keratinizing, 17% of cases non-HPV related. The glandular can be papillary hydroadenoma, which is benign, in the past given to skin adnexal tumors like sweat gland tumor and sweat gland tumors. We have Paget disease, which is malignant. This disease causes excess osteoid deposition when affecting the bone, whereas in breast it gives at nipple pseudo-inflammatory neoplastic localization in presence of an underlying tumor. In vulva instead, Paget gives a quite localized lesion without another underlying cancer. Morphology. We have a vorticarcinoma which is pushing but is not clearly invasive. You see here. Here you see the picture hydroadenoma. There is a cavity in which this papilla are growing. This process recapitulates what we see in skin adnexal tumors. You don't have pushing margins or microinvasion of stroma, so it's localized. On the right, you have instead Paget disease. So a basal layer is replaced by a nest of large cells, which are clearly neoplastic. Differential diagnosis could be melanoma, which has a similar morphology, but Paget is not S100 positive. Disorders of the vagina are vaginal intraepithelial neoplasia, squamous cell carcinoma, and the embryonal rhabdomyosarcoma, which is very rare. Morphological examination of the cervix. Insert the speculum to visualize the entire vaginal canal. Then you use a brush to take cells and do pap smear cytology for screening. The end point is to select patients who should undergo further examination, like biopsy. In cervical biopsy instead, the specimen is 2-3 cm in diameter. The stain used is Papa Nicolau stain. Here there is a comparison of normal cervical epithelium with a case of squamous metaplasia. In the latter case, HPV infected cells are recognizable. They have very clear cytoplasm, and the nuclei look shrunk due to HPV infection. These cells are called coilocytes, the cells which can form condyloma, even though its formation is not necessary. We can see there is a gland, and so this is a case of squamous metaplasia in a columnar epithelium. It is not a precancerous condition yet, but dysplasia can arise on top of it. Scene 1, if you look at lower layers, there is a non-physiological thickness to 3 cell layers instead of 1. There is a mitotic figure indicating increasing mitotic activity. There is also a loss of polarity. Scene 2, thickness of basal layers is much more evident. It almost occupies all thickness. Loss of polarity is evident as well as disordered growth and enlarged cells. Scene 3, in this case you can see that the uppermost layer is still normal, whereas in case of in situ carcinoma, also that one is compromised. And you can see here in situ carcinoma, all the epithelium is involved, but there is nothing invading the lamina propria. This instead is microinvasive carcinoma, with 2 sites of invasion. Sequence going from severe dysplasia to invasive cancer may take 2 to 10 years. Until grade 2 intraepithelial neoplasia, the process can still be reversible in 60% of cases if we eradicate HPV infection. Nowadays, the preferred term is SIL, squamous intraepithelial lesion, instead of SIN, cervical intraepithelial neoplasia. The relationships between SIN and SIL is problem about SIN is that SIN2, being in the middle, accounts for vast majority of smears and biopsies. SIL allows division into categories instead of three: low grade versus high grade lesion. High grade SIL requires strict follow-up. 80% of cases of high grade SIL develop from previous documented low grade SIL. SIL classification was introduced for clinical management of the patient. Epidemiology. Cervical cancer is the third most common cancer in women after breast and lung. The two high-risk subtypes of HPV, HPV-16 in 60% of cases and HPV-18 in 10% of cases, are related to this cancer. Target cells are immature, basal layer, or metaplastic. The oncogenic potential of HPV is mediated by E6 and E7 proteins that interfere with tumor suppressor proteins of host cells. Morphology are 80% are squamous, 15% adenocarcinoma, 5% others, so not all cervical cancers are squamous cell carcinomas. Actions of E6 and E7. E7 interferes with P21 and P27, which are brakes for the cell cycle. RB protein is active, and there is also a upregulation of MYC-oncogene. This activation of cell cycle ends in activation of proteasome pathway, which PRB degradation. Viral E6 interferes with P53 and upregulates telomerase, causing cell immortalization. The ways to detect directly HPV would be molecular genetics, but it's time consuming and very expensive, so we prefer to use serological tests. However, if we want to be quicker, we use surrogate markers, which are not a formal proof but can highly suggest HPV presence. For example, Ki67 positivity in upper portions of cervix or P16 positivity, active in cells committed to enter the cell cycle, throughout thickness of epithelium. Prognostic factors are stage of the disease, 5-year overall survival is 100%, for microinvasive more than 50%, for extension outside the pelvis, which is not so bad. And the histotype. Small cell neuroendocrine tumors carry the worst prognosis. However, primary neuroendocrine tumors of the cervix are very rare. Disorders of the uterus are: to define endometrial hyperplasia, you need to have increased number of glands in relationship with the stroma. Most forms of endometrial hyperplasia are benign, without cytological changes, but some have atypias. As we see in the picture on the right, the atypic form has higher density, and glands tend to coalesce, which is not a good sign. The tumors of the uterine body are in the endometrium we have endometrial carcinoma, exceeding frequency of cervical cancer. The explanation is that, unlike cervical cancer where we have screening with pap smear, here it's not possible to assess easily a precancerous lesion. In addition, there seems to be an objective increase in absolute numbers of this pathology. We can split in type 1 and which is endometrioid, and type 2, which is serous. Type 1 endometrioid, in 80% of cases, there are 80% of cases of endometrial carcinoma. Median age of presentation is 55-65 years. It's usually well differentiated, hence the term endometrioid, and clinically indolent. It metastasizes by lymphatic spread. It usually occurs in the context of endometrial hyperplasia. It's associated with obesity, abnormal glucose tolerance diabetes, hypertension, infertility, and sustained estrogen stimulation. Pathogenic model is, even in hyperplasia without atypia, the cells can show KRAS mutations and microsatellite instability, which then become more frequent as the passage to atypical hyperplasia occurs. The genes that allow to switch from atypical hyperplasia to low-grade carcinoma are PI3CA, beta-catenin, DNA mismatch repair genes. This parallels morphological subdivision. Morphology. On the right, there is invasive growth. There is a higher grade of atypia than in atypical hyperplasia. So the type 2 endometrial carcinoma accounts for 15% of endometrial carcinoma. The age is 10 years later than type 1, so 65-75 years. It occurs in the context of atrophic endometrium, usually less differentiated, serous and clear cell subtypes, and clinically aggressive. It metastasizes by lymphatic spread and the intraperitoneal spread, probably following an exfoliation phenomenon from tubal epithelium to the peritoneal cavity. Pathogenetic modeling is starting from an atrophic endometrium. After p53 mutation we pass to serous endometrial intraepithelial carcinoma, and finally after mutations in other pathways we reach serous endometrial carcinoma. Once again, PI3K pathway mutations play a crucial role. Other relevant genes regulate MYC and cyclin E pathways, regulation of chromatin, tumor suppression, suppressive phosphatase, PPP2R1A. Morphology. Not as well differentiated as type 1. It can have serous papillary appearance or krill cell appearance. Prognosis in endometrial carcinoma is based on the stage of the disease. Stage 1 is limited to corpus luteum, stage 2 limited to uterus, stage 3 outside the uterus but not behind the true pelvis, and stage 4 outside true pelvis or direct involvement of bladder and rectal mucosa. The second type of tumor, so we have endometrial carcinoma, and the second type is malignant mixed Mullerian tumor. It's an endometrial adenocarcinoma with a malignant stromal component. Both components are neoplastic. That is why it was called in the past carcinosarcoma. The stromal component can be leiomyosarcoma, rhabdomyosarcoma, or chondrosarcoma. The current view is that both epithelial and non-epithelial component share the same genetic defects. The mutations present are typical for epithelial tumors and not for soft tissue tumors. Accordingly, carcinosarcomas are viewed as carcinoma with sarcoma differentiations. Epithelial and sarcomatous components may occur admixed or with two separate phases. Metastases usually are composed only by epithelial components. The age of onset is postmenopausal. The prognosis is poor, and it's influenced by the age and the heterogeneity of mesenchymal component. Morphology, you can still recognize some glandular and stromal component. In the upper left picture, pinkish tissue is osteoid component. In the upper right picture, the stromal component looks like cartilage. Then we have tumors of endometrial stroma. They account for 5% of endometrial tumors. We have adenosarcomas. The suffix adeno refers to a benign epithelial component, so we have a differential diagnosis with carcinosarcoma. And then we have stromal tumors. They can be benign stromal nodules or endometrial stromal sarcomas. This is a reminder of uterine tumors analyzed according to the malignancy of their components. So, in the endometrial carcinoma, the epithelial component is malignant, the stromal component is benign. In malignant mixed Mullerian tumor, the epithelial component is malignant, the stromal component is malignant. In the adenosarcoma, the epithelial component is benign, while the stromal component is malignant. Endometrial stromal sarcomas are low-grade disease, but they relapse frequently, 36% in stage 1 disease, and can invade the myometrium. Long-term metastases can occur even 10 years after diagnosis. 5% of overall survival for low-grade tumors is 50%. Pathogenesis: in low-grade tumors, there is a chromosome 17 translocation, and this combination causes abnormal oncogene expression. For high-grade, many have specific chromosomal abnormalities with the formation of many fusion genes. So we said that we have tumors in the endometrium. Tumors of the uterine body can be in the endometrium or in the myometrium. In the myometrium, we have leiomyoma, which is benign, and leiomyosarcoma, which is malignant. The age of onset is 40-60 years. There is a high grade of recurrences, and metastasis is by hematogenous spread. 5-year overall survival is 40%. There is a complex karyotype and MED2 mutations, the latter shared with leiomyomas. That is to say that MED12 mutation is not pathognomonic for the disease, but it's a myosignature, present also in benign conditions.